his set of consents.
No. Whenever a crash is there, we will be debriefing it after that.
No, in our consent form and admission to the labor room, there's an open-ended consent which says that in case of dire emergency, we may use instrumental delivery or operative delivery. That is there included in the consent at admission. At the time when we make a decision for a crash cesarean, the person, the obstetrician who is making the decision, if the bystander or the companion is there, just explains to them and say why it is required and directs to the nurses to get the signature. But even if it is not, for example, it's a cord prolapse, you explain that. In the light of the previous open-ended consent, we will go ahead and do it and explain that later in detail. That is what we do. I think that should be quite, that is why we have the open-ended consent at the time of admission. But if there is time, if there is nothing like that, if there is a time, of course, better to get signature from both the, for the anesthesia as well as for the procedure. But suppose it is a cord prolapse situation. Suppose a rupture uterus where the baby, you think if you wait further, is likely to be lost. We don't spend time explaining as usual. Just explain to the husband or whoever is the companion that this is a problem, this is one, we have to take the baby out immediately. I'm going to take immediately for that. And please give the signature. That's what we do. And so far we never had an occasion. As you saw in our published paper also, we have written that the decision to delivery interval, decision or the code announcement to the delivery interval was 13 minutes, 1-3.
Thank you, sir.
Any other point about it? See, the small things are important. Transferring the patient, a doorway which will not allow the bed to go, transferring a patient which has so many lines to the bed. All these are the ones that waste time. And the person who makes the decision, and then somebody else coming to catheterize. That person asking for a Foley, and there you don't do all the detailed painting and all that. That is how I think we can save time. Next one.
Dear all, we are moving to the last topic of Labour Congress, a very controversial one. Should all IVF pregnancies be delivered by caesarean section? And this is by Dr. Sara Cherian from Rajagiri Hospital.
Good afternoon all. Myself Dr. Sara Cherian. Today my topic of presentation is a data sum up of the outcome of IVF pregnancies in our hospital, and thereby trying to answer this question, is elective caesarean mandatory in IVF pregnancy? Caesarean section rates are higher among pregnancies conceived by assisted reproductive technology compared to spontaneous conceptions. Less than 60% of IVF group had a full-term pregnancy, unlike 90% in the natural conception group. Decision for delivery of fetus in IVF pregnancy is usually taken by around 34 to 36 weeks. All these factors can increase the maternal and neonatal morbidity. So about the protocol for induction for IVF pregnancy at our hospital, we keep the standard gestational age for induction in IVF pregnancy as 39 weeks if it is a low-risk pregnancy. IVF pregnancy as per se is not a contraindication for induction of labor in our center. Prior 39 weeks, interference of pregnancy is done only for a major maternal or fetal indication. Some cases still we had to do elective CS because of maternal request, as patient was strictly following the advice from their IVF center. So about the study, this is a data sum up of 75 IVF patients, both maternal and neonatal outcome. It's a retrospective study. ICSI patients were 30 and IVF patients were 45. If you see the age-wise distribution, maximum number of patients were in the 30 to 34 years, and second was 35 to 39. And we had 2 patients above 50 years. About the gestational age at the time of decision for delivery, if you see the chart, around 64% could cross 37 weeks. 37 to 37 weeks, 6 days was 8%. 38 to 38, 6 was 21%, and 39 plus was 34%. So in this data, 64% could complete a term pregnancy and 34% could complete 39 weeks. And coming to a major slide about the birth weight of the babies, if we see, we could maximum number, that is 24 number, was in the above 3 kg group, 3 to 3.499. And second was from 2.5 to 2.999. This we could achieve because of our weighting policy, I believe. And less than 500 gram was 3 in our study. And about the cord blood pH of the babies, if we see more than 7, around 81 babies had more than 7, and only 3 had less than 7 pH, and it had reasons for that. One was PPROM 26 weeks, one was abruption 28 weeks, and one was PPROM 25 weeks. We had not interfered if there was not any indication for induction until 39 weeks. And same what I said before, 64% could cross 37 and 34% could cross 39 weeks. Gestational age to decide induction was 39 weeks, of which 4 came in spontaneous labor and 22 were induced. About the mode of delivery in the term patients, that is 64% who could cross 37 weeks. FTND, full term normal delivery was 22, instrumental delivery was 7, elective CS was only 10. Out of the 48 patients, only 10 underwent elective CS, and in that majority was due to maternal request. 7 was due to maternal request, malpresentation 2, placenta previa 1. Emergency CS was only for 9 patients. Indication for emergency CS was